All right. We get started, or yeah, so want to wait a couple minutes, or go for it. Bring it up. All right, guys. So perhaps we'll go ahead and get started. We're supposed to talk about TAVR and coronary disease, and which we certainly will. But in speaking with the fellows yesterday, they had mentioned that this is sort of the first structural heart talk that we've had so far this year. And so to that effect, I thought I would just kind of start at the beginning, a little bit, tell you guys a little bit about the valves that we use, other things that I think will be helpful for you. And then we'll kind of finish up with sort of tips and tricks for engaging through our valve frames, et cetera. So disclosures. So I just thought that it, start with the case. So this was a woman that we looked after previously, 69, multiple comorbidities, had a month and a half hospitalization for COVID pneumonia, big lady with a BMI of 49. STS predicted risk of mortality is 5.4%, which would actually fall in the moderate, intermediate risk range just for the STS. But given her age, not so much her age, but her comorbidities and her size, and her overall frailty, recent hospitalization was deemed to be extremely, extremely high risk. You see clearly she has severe aortic stenosis. The cath did not demonstrate obstructive coronary disease, and you can see the right heart cath numbers here, not floridly volume overloaded, but a low PA-SAT and low cardiac output and index. And so for patients like this, when we kind of talk about the gamut of treatment options, so option one is continued conservative management, medical management. Option two could include balloon aortic valvuloplasty. And then the option number three is aortic valve replacement, either surgical or transcatheter. And we'll kind of go through these step by step. So in terms of medical management, and you guys all know this already, severe aortic stenosis is a life-limiting condition. And in Valve Clinic, we counsel folks now that for patients that have severe symptomatic aortic stenosis, mortality approaches 50% at about 2 to 3 years if this is left untreated. Right on the top right, you see the old, probably one of the most famous graphs in all of cardiology from Dr. Brunwald that demonstrates sort of the cliff that you fall off once you develop symptoms. The study below also just kind of shows the curves once you develop symptomatic severe aortic stenosis and are not treated with aortic valve replacement. As of now, there are no medication options to halt or reverse the effects of calcific aortic stenosis. And in the bottom left are the guidelines. So class 1 guideline for kind of managing hypertension as you would with standard GDMT. Statin therapy is indicated for primary and secondary prevention of atherosclerosis, right? The SEAS trial looked, at statin in the setting of aortic stenosis did not demonstrate benefit. The interesting thing, so there is obviously a lot of work that's ongoing with respect to this, right? So using Yale data, Alexandra and her group just recently published a study in JAK intervention looking at SGLT2 inhibitors, suggesting that they can sort of retard the progression of aortic stenosis. There are other studies that are ongoing looking at the SIGWAT medicines as well. And so this is obviously an area of active investigation. But as of right now, by guideline, there are no medicines that we use to reverse or halt the progression of AS. So balloon valvuloplasty. So this is something that you guys will see occasionally in our lab. The main issue with balloon aortic valvuloplasty is that the results are not durable, right? We typically expect the results to last for about 3 to 6 months. Oftentimes, the AS recurs sooner. The challenge with BAV is that many of the complications are similar, right? So the sheaths that we're using is anywhere from a 9 to a 14 French arterial sheath. And so you have all of the potential complications of large bore vascular access. There's also a risk of severe aortic insufficiency, stroke risk, heart block. The prior data have been like pretty not great. This is like from the 90s and early 2000s. There are data to suggest that contemporary results are likely better. And that I think is a combination of the fact that the tools that we use, the balloons, are a lot better now than they were historically. We're much more proficient with large bore vascular access. And so for the average patient, the risk of a vascular access complication is modest. Um, but I think we find it to be useful in specific circumstances. By guideline, there's a 2B indication for BAV in sort of critical illness. And so by guideline or, for boards, et cetera, it really is like a patient on multiple pressors in the ICU, where you're doing a BAV to sort of temporize the situation until you can offer them surgical or transcatheter valve replacement. So current TAVR platforms. So in the United States, there are three platforms that are commercially available for use. Two of the three comprise more than 95% of the total volume in the total volume of valves used in the United States. The third one, which I'm not going to talk about here, is the Abbott Navitor valve. So it's the newest one. It's used more often worldwide. We haven't introduced it because we haven't really found much of a value add or a value proposition, but certainly we can talk about it. So the most commonly used valve in the United States is the SAPIEN S3 transcatheter heart platform. So as you all know, this is a balloon expandable platform. The leaflets are made out of bovine pericardium. Their latest generation uses the Resilia anti-calcification technology, which Edwards uses for all of their traditional surgical valves. The valve has a cobalt chromium frame, but it is important to know that this valve frame also has nickel. So if somebody has a severe nickel allergy, then this valve is not going to be appropriate. The leaflet positions are intraannular, so that means they're right at the position of the leaflet. So I have a valve here you guys can open and take a look at. But you can see that the leaflets are sort of at the position of the annulus, and then there is this skirt on the outside of it, which has been designed to reduce the risk of paravalvular leak. The valve comes in four sizes: 20, 23, 26, and 29. And as I said, is across the country is probably the most common valve that's used. The pivotal paper, really the paper that kind of got everything started for us in structural heart world, is this publication from 2010, which was the partner B cohort. So this was TAVR versus medical management in patients that were too sick to undergo traditional surgical aortic valve replacement. Total of 358 patients randomized to medical management, which included balloon aortic valvuloplasty in about 2/3 of patients. Within 30 days, and then another 20% after. And the primary endpoint for the study was all-cause mortality. And so this is the famous event curve, right? There is a 20% absolute risk reduction in mortality at 1 year, from 50% to 30%, with a number needed to treat of 5. And so this is sort of what we all quote when we're talking about sort of the mortality benefit of transcatheter aortic valve replacement. Most recently, right, so with this particular valve, the most recent largest study is the PARTNER 3 low risk. So initially PARTNER was in inoperable candidates, then high risk candidates, then intermediate risk candidates, and then the largest big study recently is in low risk patients. And that's the study, PARTNER 3. So again, randomized between TAVR and traditional surgery, with a primary endpoint, which is a composite of all-cause mortality, stroke, or CV rehospitalization at 1 year. And then these are the event curves for that primary endpoint. And again, you see sort of a significant risk difference between the two arms. When you look at all-cause mortality, There is the mortality benefit was not found to be statistically significant. For stroke, it just was statistically significant. And then for when you look at death or disabling stroke, there was a lower rate of death or disabling stroke at 1 year with TAVR compared with traditional surgery. Much of the difference was driven by this change in rehospitalization. And then when we talk about the hemodynamics, the valve gradients, so with this platform at 1 year, the mean gradients were higher with TAVR than with traditional surgery. And this is something that we're going to come back to. We're going to come back to in a little bit. So these are the mean gradients as assessed by echo, both at 30 days and 1 year. More recently, the 5-year data were presented and published in the New England Journal. And in general, the results now hold for 5 years. And then they weren't formally published at 6 years. So the study required 10-year follow-up by the FDA. So they published 5 years. The 6-year data are available on the FDA website, again, are grossly similar. But you can see here that with respect to the primary endpoint, death, CV death, and all stroke, the results are broadly concordant, and there is no statistically significant difference between transcatheter versus surgical aortic valve replacement. Gradients, again, are durable, but you see a higher echo-derived gradient with the SAPIEN platform compared with the comparable surgical platform. I did want to mention, because this is going to come up in discussions for you all, the most recent study with this platform that was recently presented is the early TAVR study, right? So the early TAVR study was presented and published in the New England Journal in October, which looked at patients that had severe asymptomatic aortic stenosis. So you had to be 65 years or older, had to have classic severe aortic stenosis as classified with a valve area of less than 1, or a mean gradient of greater than 40, or a peak velocity greater than 4. So no low gradient AS, nothing like that, just kind of classic severe aortic stenosis with preserved ejection fraction. All of these patients had their asymptomatic status confirmed by either a negative treadmill stress test. So it was negative if they achieved 60% of their age predicted METs. So it's like on a curve, you basically just put them on a treadmill, see what their what their METs equivalent is, and then look on a chart to see if they achieved greater than 60%. And then if they were unable to perform a stress test, orthopedic issues, et cetera, by detailed clinical, but this was very much in the minority of the patients. And then they have an STS of 10 or less. The primary endpoint here is a composite of all-cause mortality, all-cause stroke, or unplanned CV hospitalization. And here I want to draw your attention to that unplanned CV hospitalization, because it was defined as any cardiovascular hospitalization through the ED or admission from clinic for therapy intensification. So like if you saw somebody in clinic, you felt that they weren't doing well, you brought them into the hospital, diuresed them, treated them, that counted as a CV hospitalization. And importantly, any aortic valve intervention in the clinical surveillance arm or re-intervention that occurred within 6 months, because the thought was that if somebody's asymptomatic, you see them in clinic, you generally tell them to come back in 6 months. If in that intervening time they got a TAVR procedure, they counted toward the primary endpoint. And so these are the curves. And again, when Philippe Genereux presented this, showed this curve, and they demonstrated a number needed to treat in the primary endpoint of 6 at 2 years. And, everybody kind of stood up and started clapping. And I think that it is sort of important, but I do want to just offer you all a little bit of nuance for how we think about it. And, I don't know if John is on, Victor, you guys are welcome to offer your thoughts as well. Importantly, there's no difference in all-cause mortality between the two arms. Okay, and you can see the curves are essentially overlapped through 5 years. So there's no difference in all-cause mortality. At 5 years, there was this divergence in terms of the risk of stroke. Now, again, this is not statistically significant, but I think sort of interesting. And I don't have a great explanation as to why this is the case. And remember, the risk of stroke is lower in the TAVR arm, not in the surveillance arm. But the difference, obviously, was driven by unplanned CV hospitalization. You can see clearly there's a big difference, and that big difference is early on, right? So it's right kind of within that. So 6 months is right here. So we're talking about kind of the curves starting to differentiate even earlier, but really over here. And part of this is what I think what makes it a little bit challenging, right? Is that it's not like it is randomized, but it's not like blinded, right? And so all of these patients are coming in with severe, kind of quote unquote asymptomatic severe aortic stenosis, know they have aortic stenosis, know everything there is to know in the public literature about aortic stenosis, are randomized to clinical surveillance. And you see sort of the separation very, very early on. I will say, if you use a tighter definition of the hospitalization for heart failure, so if you don't use that primary definition, but you use this tighter definition, which is hospitalization for heart failure treated with IV diuretic, inotropic therapy, intra-aortic balloon pump, ventilator if you had pulmonary edema, or hemodialysis for volume overload. This is what the curves look like. So there is still likely a difference with reduction of these events in the patients that undergo TAVR compared with the enhanced clinical surveillance. And so I don't want to, I don't want for you all to get the impression that, the study was, it wasn't a well-designed study. Like, it was a well-designed study, but I think this is a little bit of nuance. And I think for us, as we counsel these patients in the clinic, it gives us a little bit more flexibility to offer sort of more personalized treatment for these patients. And so if you have if you have somebody that's very adamant about getting treated, I think this sort of gives us some data to guide that decision and to tell them that, treatment is very reasonable in appropriately selected patients. If you have somebody that really kind of wants to, not undergo treatment and kind of wants to drag their feet a little bit, you can sort of rest assured that there is not going to be a mortality difference with early treatment compared with traditional treatment. Maybe I'll pause there if you guys have any thoughts or.
Yeah, no, I think it's, as you said, it's hard to kind of conciliate results when you have, so definitions are in the first 6 months, and then suddenly you see the curve separating early on up to 6 months time one, and then they go in parallel. So caught my attention. It's exactly what was predicted in protocol. But anyway, as you said, I think this is, I don't know how these results change your practice from now on. When you get asymptomatic patients early on in the disease stage, if you're, more aggressive indicating that like in the beginning of the disease process, or if you just continue doing what you're doing before.
I think it would change my approach, because one of the things is when I see a velocity over 4, I always, in my mind, there is data to suggest that there's some increased risk of mortality as your velocity rises, right?
Correct.
So then I'm thinking, geez, it's 4.2. Should I push harder to get this guy fixed because he's at risk? And now this suggests that, at least for a few years, there's no real mortality difference if you push them. So if somebody really doesn't want to get fixed, then you can rest assured that they'll do just as well.
They done a cost benefit analysis excluding the patients that crossed over to get a valve early, like these heart failure.
Yeah.
versus-
I'm sure that's all coming.
Yeah,
Yeah.
so that would
So
be
relevant.
interesting to see.
I imagine, for what it's worth, there generally is a cost benefit. Like there's a benefit in terms of that with respect to earlier treatment, and I think that's part of the reason why, at least on the structural heart side, we often try to find patients that have severe aortic stenosis because of specifically what you mentioned. Hospitalizations are expensive,
Right.
Right, and heart failure hospitalizations, especially, like it's one of the, if not the most common reason why folks are hospitalized across the country. And oftentimes it's not just one, but multiple. But I'm positive that those data are coming.
Yeah, because I feel like that would be a big driver for
For sure.
If you had a somewhat younger patient, asymptomatic,
Yeah.
and given that you're expecting the TAVR to be good for maybe 10 years, would you treat them differently?
Yeah, so that's a great question, and I think that really goes to the heart of some of the decision making that we do in the valve clinic. It's important to note for this study and for all studies, the lower bound for the age threshold is 65, right? And so across the country, like by guideline, if you are less than 65 and low risk, you are not a candidate for TAVR. Now, that's very different from what's happening in actual clinical practice. And when you look at registries and Vizient data, et cetera, up to half of patients that are undergoing treatment that are aged less than 65 are actually undergoing TAVR. So it's that part is very different. What you're describing, I think, is really important when we think about the lifetime management of these patients, right? And so, especially when they're younger, it does factor in, right? So once you're like past 70, we generally, like, our bias is generally toward treatment. If you're particularly young and you have no evidence of any cardiac damage, like your BNP is normal, for some of these patients, we'll sometimes get an MRI to look for late gadolinium enhancement or fibrosis, that sort of thing. If all of that is unremarkable, then I think there is potentially a case to be made to try to kick the can down the road just a little bit, because that may be the difference between one intervention over the course of your life versus two. So, okay. All right, good. The other platform that is used most commonly in the United States is the Evolut FX transcatheter aortic valve. So this is a self-expanding platform that is made, the leaflets are made out of porcine pericardium. And it has a nitinol frame, right? And obviously you guys know all about nitinol, but it has very temperature specific properties, right? And so nitinol, at least the specific formulation that we use in the Evolut valve frame, is extremely flexible at very low temperatures and becomes rigid and assumes its normal shape at regular body temperature. And so that particular property of the metal, of the alloy, is leveraged to create this particular platform. So what happens is the valve is it's put in an ice bath, and that allows us to load it into the delivery system. When it enters the body, it warms, and as it warms, it assumes its more rigid conformation, and that's what allows us to use this use the self-expanding. And so this is very similar to like videos. But it's basically we line up to kind of where we want to put the valve. We start a pacing run, and then we're kind of rapidly deploying the valve so that it can assume its native conformation. The biggest advantage of this platform is that we have the ability to recapture and redeploy up to a certain point. So like up to here, if we're not happy with the position, we can actually just recapture it and basically start again. which is very different from the Sapien platform, which is basically you're lining up a dot, starting the pacing run, and blowing up the balloon. It's similar to what we do in everyday interventional cardiology. But this at least gives us the chance to do that. So this valve also is available in 4 sizes. The pivotal study for this was the Evolut. So the most recent one is the Evolut low risk study, for which John is the national PI. And again, the data are more similar than not. Like they're different. There's some nuances between the 2 low risk studies, but in general, no difference in all-cause mortality or disabling stroke at 1 year. Mortality, there was a difference in the risk of stroke with lower stroke in the TAVR arm. And then heart failure hospitalization also is different. So that was the 1-year data. In terms of hemodynamics, so here there's a little bit of a difference where the Evolut platform has lower echo-derived gradients. The gradients are generally single digits, less than 10, and that's sustained. These are the 4-year data, again, showing essentially parallel curve, showing that the results that were achieved at 1 year are sustained through 4 years. Again, all-cause mortality, disabling stroke, all favoring TAVR compared with surgery. And then the 5-year data are going to be presented at ACC, presented and published at ACC. So keep an eye out for that. Treatment guidelines, again, we don't really need to go through this. Class 1 indication for these patients to be seen in a heart team setting. This is all kind of in the guidelines. The way that I kind of broadly think about it is that valve replacement, AVR, is indicated if the patient has severe AS and either symptoms or if their ejection fraction is not normal. For these asymptomatic patients, when we see them, we often will order an exercise stress test, but now with the results of early TAVR, you are on more firm ground to move directly to treatment. If the patient's high or prohibitive risk, in general, they undergo TAVR. If they're age 65 and low risk, it's typically surgery. And if they're particularly young, 50 or less, we would think about a mechanical valve. Between age 65 and 80, either is probably fine, and greater than 80, generally will prefer TAVR. But in general, I think for most patients after age 70, most of those patients are getting, especially if it's isolated aortic valve disease, they get TAVR. Choosing between SAVR and TAVR, again, 65 and low risk, TAVR is not formally indicated for these patients. If there's concomitant valve disease, concomitant aortopathy, et cetera, coronary disease, they often will get surgery. Bicuspid is a little bit challenging because bicuspid isn't like a one thing. It's extremely anatomy dependent. And so if they have sort of Sievers 1 anatomy with partial fusion of the right left cusps, that's very favorable for TAVR, and we will offer them TAVR. If they have Sievers 0 or kind of heavily calcified REF-A, the risk of annular injury for these patients is much higher. And so we would, in general, if they're a good surgical candidate, prefer surgery. To Rob's point before, it's important to think about lifetime management before the first valve goes in. The lifespan of these prostheses is not currently known, but we expect that they'll last about 10 to 15 years. The reason why it's not well known, right, is that, so as I showed you, partner B was presented in 2010. Most of those patients had 50% mortality in the medical management arm and 30%. Like even if you got a perfect TAVR, still your mortality was 30% at 1 year. There are 10-year data series that are coming out now in general, looking pretty good. And as I mentioned, the low risk studies they've mandated 10-year follow-up. And so we'll have better data. And then how do we choose between Evolut and S3? So Evolut, as I said, is self-expanding. So that means that it has a lower kind of opening force, which means if you have a ton of calcium in the annulus, or if there's a ton of calcium in the LVOT, kind of rapidly blowing up a balloon can cause injury. And in that situation, a gentler expansion, maybe a little bit, maybe better. The echo-derived hemodynamics are better with Evolut, but the frame is taller, and so coronary access can be a little bit more challenging. We'll talk about that in a second. We can align the commissures with more precision, which means that we can make it so that a post is not right in front of the coronary. Again, makes it a little easier. Historically, the pacemaker rates have been higher with Evolut than with Sapien, but we've done a lot of work, and now the rates are more comparable. I do want to mention one additional study that came out relatively recently, which is a SMART study. So this is self-expanding versus balloon expandable in small aortic annuli. And so this kind of goes to the point of A, the durability of the valve, and B, the fact that the hemodynamics may be different in between the two platforms. And this difference is most stark in patients that have small annulus, right? Because in these small annulus patients, we can put a Sapien valve in, but the valve we put in is a lot smaller than the comparable Evolut valve. The gradients tend to be higher. And so it's unclear whether this functionally makes a difference. And so this study looked at those patients, randomized small annulus patients, to the Evolut platform versus the Sapien platform. The co-primary endpoints, the first one was sort of hard outcomes of mortality, disabling stroke, or heart failure rehospitalization. And then the co-primary endpoint number 2 was looking at bioprosthetic valve dysfunction through 12 months. Now, as expected with, on the left here, these are the valves that were implanted, the sizes. So you can see that with the Evolut, we put in larger valves, 26 or 29, mostly versus a 23 millimeter Sapien S3. There was no difference between the two platforms in terms of mortality, disabling stroke, or heart failure hospitalization at 1 year. Okay, so this is the first co-primary endpoint, no difference at 1 year. But when you look at the definition of bioprosthetic valve dysfunction, there was a big difference between the Evolut and the Sapien platforms. And this was driven almost entirely by this hemodynamic valve deterioration, and then this non-structural valve dysfunction as well. And the first one is just the gradient, right? So 32.2 versus 3. So this just basically means that with the Sapien valve, especially with small annulus, we're putting 20, 23 S3, the mean gradient is oftentimes greater than 20, which is almost unheard of with the Evolut platform.
So this is just the gradient of the year?
This is just the gradient of the year. Yep, HSVD is mean gradient of 20 or more. And
So does that mean that something bad happened to the valve over the year? It's just that way when it was put in?
no, so that's right. So in general, these gradients, so when we look at these gradients at 30 days, they're almost inevitably higher with Sapien compared with Evolut. Now, these are the echo-derived gradients. And there are, there's active discussion in the field whether this is purely an echo-derived phenomenon or if this is sort of real. And oftentimes if you measure them invasively, the difference is not as stark. So there's an echo phenomenon called pressure recovery, et cetera. But, we're not bringing these patients to the lab every month or every year to recheck cross their valve. And
These gradients are that high immediately after the procedure?
they're generally, they settle out at about 30 days. So yeah, at 30 days, especially with the smaller valves, with 2023 S3, the gradients can be higher. And so again, these are the secondary endpoints. So the mean gradient, right, is the mean of 16 with Sapien versus a mean of 8 with Evolut. That there's a difference in the EOA, and then these are the HSVD. So this is the gradient greater than the gradient greater than 20. Now again, so the point that I want to make, right, is that again at 1 year, there's no difference in hard outcomes. This has been looked at extensively with a partner family of studies. People have looked at small annulus. Becky Hahn just published a paper on this last week or 2 weeks ago. We wrote the editorial. there is no difference in mortality that has been observed even to 5 years. But it is something that is, that at least we think about. And this is in the TAVR world. In the surgical aortic valve literature, like it's pretty clear that higher gradients, especially once you get to like around 22, 23, 24, the higher gradients past that are associated with worse outcomes. So this is like the big thing that we're, as I said, it's an area active investigation. All right, a few more things. So TAVR and coronary disease, so as you know, both are comorbid and present in many patients, and a lot of these patients are going to require PCI post TAVR. This is just from all of the initial studies looking at the prevalence of coronary disease. In the earlier studies, the ultra high risk patients, more than 2/3 of these patients had coronary disease. Now, again, as you all know, there are conflicting data on PCI prior to TAVR in these patients. So this is a study from the Cleveland Clinic, almost 2,000 patients. In these patients, a quarter of them had obstructive coronary disease and high or extreme risk coronary anatomy, right? And they define high risk and extreme risk over here. So high is in multiple territories, and extreme is triple or left main. In this study, they found no difference in MACE, which is defined as acute coronary syndrome, heart failure, hospitalization, or stroke, among patients that underwent TAVR that had coronary disease versus non-obstructive coronary disease. There is a difference in unplanned coronary revascularization among the patients that have coronary disease after the TAVR. But this study, at least, and again, like it's a single center at Cleveland Clinic. Their structural program, it's everything there is obviously world class. But they found that TAVR is safe among patients even with pretty significant coronary disease. They do almost exclusively balloon expandable. They, at least historically, they implanted sapien in the vast majority of their patients. And so the guidelines right now, again, are relatively vague, in terms of revascularization. In general, we try to obtain the coronary anatomy before the TAVR, either through the CTA or with cath. In general, it's reasonable to consider PCI prior to TAVR if they have left main or proximal vessel disease. But again, outside of that, the real benefit is a little bit challenging. I do want to mention there was a big study that was published at ESC last year, presented at ESC last year, called Notion 3. So this is PCI in patients undergoing TAVR. It included patients with severe AS and coronary disease in one or more lesions. And coronary disease here was defined as an FFR of 0.8 or less, or a lesion severity of greater than 90% or more. Okay, so this is the big difference for this study compared with others, activation, et cetera. So 90+% or positive FFR. And the endpoint was MACE, which is death MI, urgent revasc, and then they also looked at bleeding, or safety, so bleeding, AKI, stent thrombosis. The primary endpoint, there was a 30% difference between the patients that were treated with complete revascularization, so lower in the patients that were revascularized compared with conservative therapy. And the revascularization, 2/3 of it happened before the TAVR. I think about 10% got it concomitant, and then the remainder was sometime after. But again, so this got jumbled, but this is all-cause mortality. No difference in all cause. The curves eventually are starting to diverge a little bit, not statistically significant, but at 1 year, 2 year, 3 year, no difference in all-cause mortality between the two arms. For MI, again, the curves are starting to diverge. At 1 year, they seem to still be awfully similar. And urgent revasc is sort of where the biggest difference is, where you see far lower rates of urgent revascularization with the complete revasc arm compared with conservative therapy.
The numbers at 5 years are incredibly low, though. It's hard to
Absolutely. I mean,
make conclusions from that.
there were like 445 patients that were randomized from the very beginning. And so again, I'll open for discussion, would love to hear kind of what everyone thinks. But, so again, and then obviously, as you can imagine, in the patients that underwent PCI, bleeding is higher, although the other safety signals seem overall reassuring. And then when you look at the subgroups, really the one interesting is that this was mostly there was sort of a difference, in the patients that had 90+% lesions, compared with sort of the overall group. And so, so again, like I think I'd be interested to hear your thoughts. I think for my perspective, I guess, is that in general, it's likely safe to treat these patients with TAVR, especially if they don't have symptoms of like angina. If they don't, that's kind of the main thing that I think. But these data also lend, they put you on firmer ground if you want to sort of offer a more complete revascularization up front. Again, knowing that at least in those first few years, there likely is not going to be a difference in mortality. There may be lower MI, rates of MI, or urgent vessel or urgent revasc.
Amit, can you comment a little bit of timing of PCI, concomitant versus upfront? It's a recent analysis from the TVT looking at those two, because I guess one of the I don't want to say concerns is the patients get a diagnostic cath and they get scheduled for the PCI and ultimately for TAVR, delaying what's the main pathology. So what are your thoughts on timing of PCI?
Yeah, so to some degree, like I think these are probably the best data that exists right now. You're right, there was a study that just came from the TVT registry that I think broadly demonstrated modestly better outcomes with PCI prior to TAVR. I think that it's, again, like as with early TAVR and some of the other things, it's sort of an individualized treatment decision. I think you can rest assured that at 1 year, whichever treatment option you select, is likely not going to be associated with a difference in mortality. I think personally, the way that I think about these folks, right? So if you identify a 90+% lesion, in general, like our bias has been to treat those patients. I think for kind of more intermediate to severe lesions, a lot of it is, depends on the lesion severity, the complexity of treatment, and then the patient's other symptoms. If they're clearly having angina, then our bias has been to treat these patients. But otherwise, kind of for moderate to severe lesions that are not proximal vessel, like left main, proximal LAD, et cetera, at least my personal bias has been to defer treatment for these patients until after the TAVR, because these patients oftentimes have calcium everywhere. It's not like a type A lesion that we're stenting. They oftentimes may need lesion modification for appropriate. And then the other important thing is the antiplatelet regimen afterwards as well, right? So oftentimes these are old patients, high bleeding risk. And if you stent them, then you're committing them to dual antiplatelet therapy. Whereas after TAVR, in general, we do single antiplatelet.
Yeah, and I approach them a similar way. And so just for the sake of discussion, leaving behind moderate disease, does that change your valve selection?
Yes, so that's a great segue into the next point. And so there are differences. So when we're looking at cannulating the coronaries after the TAVR, there are a number of factors that influence success of cannulation. So there are some anatomic factors, as you can see here, which include the STJ dimensions, the sinus height, the leaflet length and bulkiness, sinus of valsalva width, and the coronary heights. The coronary heights really are key because if the coronaries are low, in general, it's going to be hard to cannulate the coronaries irrespective of the valve that you choose. There are also differences, right, with the device and procedural. So commissural tab. So this refers to where the posts on the valve frame are, the sealing skirt height, and then the valve implant depth. The depth is interesting because in general, for many patients, a higher depth of implant, so more in the aorta, is associated or results in fewer pacemakers, right? The conduction system sits underneath of the valve. And so if we implant it really deep, that's going to increase the risk of conduction system abnormality. But the cost of that is potentially making it a little bit more challenging to engage in the coronaries after the TAVR is complete. For many of these patients, just sort of as a tip, if you're planning like an elective PCI or something like that, it sometimes can be helpful to get a CT scan before. We can look at it with you on our planning software. We can identify where the commissures are. We can find a good angle, like a good orthogonal angle that you can use to cannulate the coronary. So that's something that sometimes can be helpful. These are some of the other dimensions that are sometimes helpful, and I'll sort of give these slides so that they can be presented. But some of this also matters, when we're thinking about which valve we're going to select, and is helpful can be helpful for you guys because all of these dimensions are sort of known a priori. How big the cells are, what the height is in different areas of the frame, how long the skirt is, etc. So this was the main thing, like one of the take homes that I wanted to, because I think this will be helpful for you guys as you're engaging these coronaries. So with the SAPIEN valve, the frame is shorter. As I said, in general, the methods that you're using to engage the coronaries are very similar to what we normally do. You don't need typically to change the catheters that you're using, etc. It still can sometimes be harder if you have effaced sinuses, if the coronaries are low, if the leaflets are bulky. But in general, the approaches are very similar. For Evolut, there are some differences. So I'll kind of pass this around again. So this is the Evolut valve. But you can see here that, and you'll notice this on Flora, but there are these C tabs up here, and these are sort of what connect the valve to the delivery system that allow us to sort of position. But there is so one of these tabs, one of these circles is open, right? This one's open, and then this one back here is closed. But what you want to do is you want to go LAO 2025, take parallax out of the frame, and look to see where this C tab is. If the C tab is on the inner curve of the aorta, that's good news for you, because so again, it's sort of hard to see here, but that open tab lines up with this post right here. So if that's on the inner curve, it's going to look like this. So this is kind of looking down the barrel of the valve. If that's on the inner curve of the aorta back here, that means that your posts are going to be away from the ostia of the coronaries, and you should be able to sneak through one of these cells. These cells are actually all pretty big, and the current generation, they actually cut this out, so they're even bigger with the Evolut FX Plus. If the C tab is not on the inner curve of the aorta, then you're at risk of one of the posts being kind of right in front of the coronaries, and that's going to make your job a little bit harder. As I mentioned, the last two generations of the valve allow for commissural alignment. And so now when we're putting the valves in, we can do our best to orient the valve so that the posts are offset from the coronary ostia. But this is sort of like, if it's STEMI middle of the night, this is like these are some tips that can be helpful to help gauge the likelihood of success for cannulating. Okay, so that's one thing the CTAB. When you're accessing, oftentimes it can be helpful to perform an aortogram with a pigtail. This gives you a rough overview of where the coronaries are and which cell you have to target. So that's sort of number one. Then number two is selecting the catheter. So oftentimes you want to downsize the catheter. So in general, you want to downsize it by 0.5 centimeters. Instead of a JL4, you'll be using a JL3.5. And again, that's because that secondary curve is not going to be sitting where you normally want it to. You also want to try to engage the ostium coaxially. So you want to use the J wire to try to just get into the appropriate cell that allows you to kind of get through. In general, you do not want to use EBU XP guides for these because you're at risk of getting tangled in the valve, and you don't need the backup. The frame will hug the catheter that you're using. And so even with like a JL3.5, JL4, and a guide liner, you'll have all the support that you need for any sort of PCI. And then, as I mentioned, the other thing is that you want to try to approach the coronary coaxially, use the wire. The wire is your friend. And then you can also, I would just be very liberal with the use of guide extension catheters, guide liner, et cetera. You just need to be kind of close with the guide, and then you can advance the wire, advance the guide liner, get it in position. And then when you're in position, again, you're going to have all the support that you need to do what you want to do. So again, this is what I was mentioning. Engage coaxially. Again, you have to be just pretty close, and then use a guide liner. And then when you're disengaging, so this also is key. So after you do the PCI, you want to remove the guide catheter over the guide wire. So you leave the wire in the coronary, and then you want to bring the catheter back, so that you've cleared the frame, and then you can kind of take everything out. What has happened in the past is the catheter kind of getting caught in one of the cells, and then sort of taking the valve with it. And that obviously is concerning. And so you just want to do your best to, kind of clear the frame. And then otherwise just remove the J. So again, aortogram, selecting the right catheter, approaching coaxially, engaging with the use of, and then guide extension catheter, et cetera, and then just being very careful about disengaging safely as well. I'm done. The last thing I want to mention is antithrombotic therapy after TAVR. Historically, it was dual antiplatelet therapy. We've looked very carefully at this in terms of different strategies with anticoagulants, et cetera. But in general, now we've settled on single antiplatelet therapy for the vast majority of our patients. They go home with baby aspirin alone. If they have an indication for oral anticoagulation, then it's typically, or if they just have, like, say, paroxysmal AFib, then it's just oral anticoagulation, no antiplatelet. If they've had recent PCI, then we favor like a dual pathway strategy of oral anticoagulation and P2Y12, drop the aspirin. There are multiple trials that have worked this out. This is the patient that, I mentioned to you before. We eventually did a TAVR, got a great result. The mean gradient went from 46 to 3. She went home with TAVR thereafter. So in conclusion, severe AS, life-limiting condition with a mortality approaching 50% at 2 to 3 years. Contemporary strategies, including for treatment, include transcatheter versus surgical AVR. Coronary access is feasible with the current generation platforms. We've done a lot of work to try to make it as easy and as straightforward now as possible. But it is important to know the valve frame design and what the commissural alignment is, because that's going to be the biggest piece of information that's going to help. And then the future generation, future directions, the valves are getting better in terms of coronary reaccess, in terms of their durability, ease of implant. But we're looking at a broader treatment population. So asymptomatic severe AS now is much more common. Trials are ongoing for moderate aortic stenosis. So if you have symptomatic moderate aortic stenosis, those trials are ongoing right now as well. That's all I got.
That's a lot.